So looking at how vital and how energetic one is can also be a good determining factor in looking at cognitive decline or decline in general.
Welcome to Personalized by Vitamin Lab, the show where we dive deep into the world of personalization in healthcare. I'm your host, Dr. David Duizer. Please remember that the following discussion is for educational purposes only, and it's not intended to diagnose or treat any disease. Speak with your healthcare practitioner first before integrating anything that you learned today. Join us as we explore the remarkable stories, breakthroughs, and possibilities that come with the pursuit of personalized healthcare. Welcome to Personalized by Vitamin Lab. I'm your host, Dr. David Duizer, and it's been a privilege to welcome back a thoughtful colleague and respected leader in the field of healthy aging, Dr. Romi Fung. Dr. Fung is a naturopathic doctor and a PhD candidate in aging and health at Queen's University. His work stands on a foundation that stretches from rigorous academic training to deep clinical commitment, all guided by the classic naturopathic principle of Duizer, the physician as teacher. He's devoted his career to understanding cognitive decline and dementia, believing that the brain cannot be separated from the body. When metabolism, inflammation, hormones, and lifestyle shift, so does our cognitive trajectory. He works every day to bring that truth into clinical action, helping patients preserve and protect their most precious asset, their mind. Dr. Fung's education includes a Bachelor of Science in Health Sciences from Simon Fraser University, his Doctor of Naturopathy degree from the Canadian College of Naturopathic Medicine, a Master of Science in Aging and Health from Queen's University, and his ongoing doctoral research in the same program. Along the way, he's completed in cognitive decline, dementia, precision nutrition, functional medicine, and the Bredesen Recode approach. And he also holds prescribing authority in British Columbia. In addition to his clinical practice, he serves as adjunct clinical and academic faculty at CCNM, helping train the next generation of naturopathic physicians. This is our second conversation together, and I asked Dr. Fung to return to discuss a topic that's becoming increasingly urgent: the laboratory testing and clinical tools we can use to personalize prevention strategies for cognitive decline and dementia. He's poured years into understanding this field, and I'm grateful that he's here to share his insights. With that, let us begin. Enjoy our episode with Dr. Romi Fung. Welcome back to another episode of Personalized. I'm your host, Dr. David Duizer. Thanks so much for tuning in. We're really excited to have our first repeat guest, Dr. Romi Fung. How you doing, Romi?
Doing well. How are you, Dr. Duizer?
I'm doing well. I'm super excited to chat with you. We know each other, we chat. I've been following your career. I'm really excited about the work that you're doing, the clinic you're building, the support that you're providing people. And I wanted to have you on again so that I can, just because, we have more to talk about. And so today we're going to dive into dementia prevention strategies, because I think as a clinician like myself, I've been doing this for 10 years. We have a longevity stream in our practice. People are trying to live longer and be healthier. And dementia is another one of those silent conditions for a lot of people. And if it doesn't run in the family, then they can just have this kind of low grade stress. Do you find that with people, that they're just kind of like worried, is this going to be me?
Absolutely. I find that a number of people who are now finding their ways to actually looking into prevention and taking proactive approaches to their cognitive health. One of the most common reasons is that my family member has it, whether that be my mom or dad or my grandparents, some form of family member, maybe even the whole family. And thus, there's this discussion of getting genetic testing done when it comes to assessing your risk for dementia and Alzheimer's.
Can we talk through that process? So the whole show here, we're about personalization in both career, but personalization in our patient care. What might that look like? When would you decide to do tests for someone? Is it just if they're interested, or what is your criteria for even recommending the assessments?
I think the earlier the better. Today is the best time to get yourself started when it comes to your cognitive health. And depending on where you're at in your symptomatics or even asymptomatics can determine what can we start off with first.
Yeah.
As I mentioned with genetic testing, I think that's always a great way to start testing. And the most common gene that is tested now for your Alzheimer's risk is the apolipoprotein E, or ApoE for short.
Oh, I'm glad you brought it up, Romi. People come with big lists of tests and they want to know, okay, what's the priority here? And often I'm the kind of functional treatment guy. I want to make sure that people are exercising and eating as best they possibly can. But I find myself drawn to just knowing the ApoE status, like just having that done first. So I'm really glad you brought that up first. Can you speak to kind of what is ApoE and how is it assessed and what does it mean?
So apolipoprotein E, as it states, it's not necessarily a gene directly related to dementia and Alzheimer's disease. But if we just look back at the apolipoprotein pathways, apolipoproteins are involved in lymphic transportations, repair, and for specifically apolipoprotein E, it is more specific to the membranes and the nervous system, so the myelin sheath, and mostly produced by the astrocytes. So we're looking at cholesterol metabolism and maintenance in the brain by testing the genetic factors of ApoE. And when you do test for ApoE, as it's a gene, there's 3 alleles and a pair of alleles. So you either can get apolipoprotein E2, 3, or 4. And when you're tested, of course, you get 1 copy from mom and 1 copy from dad. When you get apolipoprotein E3, then that is a regular, normal kind of risk. When you have a copy of the E2, that is a protected risk. And then when you have ApoE4, your risk is increased. If you have 1 copy of the E4, then your risk is increased by about 2 to 3-fold. And when you have 2 copies of the E4, then your risk is increased by about 7 to 8-fold.
Okay. So 2 to 3-fold and 7 to 8-fold above what E3 risk? What is the risk in the general population? Do you know what that number is, or like a ballpark?
I think with some of the literature, I read some of the literature, is that about 60 to 70% of us will be likely ApoE3, and then about a third of us, so about 30%, is going to have one form or at least 1 copy of the E4.
Okay. What is the risk of dementia for someone who has an E3?
It'll be 1.
Okay. Got it. Understood. What if the person comes back and it's E4, their warning signs come up? What are some of the other tests that could be helpful? Or is there something that can be done about the E4, for example? Or what are some of the other tests that you might then turn to?
Absolutely, there's a lot can be done. Even when you have the ApoE4, which means that your risk is 7 to 8-fold, which is quite high for a lot of people. There are many things. I would always want to keep testing and monitoring my patients with ApoE4 with their lipid panels, apolipoprotein, ApoB, and even looking at other cardiovascular risks, just making sure that their cholesterol panels are not necessarily elevated. Because if they are elevated, and I do have a number of patients with the E4, whether that be 1 copy or 2 copies, you would know the elevation of the lipid panel and the cholesterol as we test every 6 months or so once we get a good handle on that. So with these kind of patients, once we get a good handle, we're testing every 6 months about your triglycerides. Clearly, triglycerides is a key factor, and making sure that if we do see any fluctuations or elevations of triglycerides and LDL specifically, that we maintain that to be at a good level.
So ApoB, triglycerides, lipid panel in general. What else could be done?
I think we started having this kind of movement about testing Lp(a) as well. And although there's not really much evidence about Lp(a) in terms of interventions, I think so far there's a couple studies talking about Lp(a) being affected by statins. I think statins can increase your Lp(a), but doing Lp(a) can at least help us see is there a genetic risk or genetic factor involved in cholesterol.
So let's say we're someone. I'm speaking for a friend. We're someone who has an E4, E3. So 1 copy of E4, 1 copy of E3, but normal cholesterol. But we still want to go all in. Cholesterol can't be the only part of the story. Like, what else can be assessed here to make sure that I have all the objective data before I get to my treatment?
I would look into other cardiovascular measurements such as homocysteine. Homocysteine is big. Homocysteine being the metabolism of methionine, and it tells us more about your cardiovascular risk and can be easily treatable with B6, B9, and B12.
So do you have a threshold, like a level of homocysteine that you're trying to achieve with this patient population?
Conventionally, the range you'll see on the reports will be up to 15. Anything above 15 is going to be elevated. My threshold is going to be 7. And I do want my patients to be about 5 to 7.
Wow, that's nice and low.
But you don't want it too low because we do know that homocysteine is needed for the methylation pathways as well. So we don't want it close to 0 or 1 either. So about 5 to 7, I find, is that sweet spot.
What does homocysteine do? Like, why is it important here?
Why is it important? Well, I kind of like to describe it as almost like a waste in our metabolic waste. And if we do create homocysteine, we need to convert it into a form that we're able to excrete it out easily so that it doesn't harm us. Because it's the accumulation of homocysteine that could lead to damage in the blood vessels, so oxidative damage in the blood vessels, and that could lead to things like vascular dementia. And there's also factors of elevated homocysteine or homocystinemia that could affect nerves, nerve tissue, cognition, and so forth. So keeping homocysteine levels at bay tends to be that sweet spot for optimizing your cognitive health.
Vitamin Lab revolutionizes personalized supplements, empowering health practitioners to create tailored supplement formulations that address each patient's unique needs. Bring personalized health to your practice and choose from over 200 professional-grade ingredients to create vitamin formulas that improve patient adherence and result in tangible outcomes. All ingredients are sourced from the world's most trusted suppliers, and Vitamin Lab provides hands-on support to help you formulate and launch personalization to your patients. Say hello to a new era of personalized supplement solutions. Go to getvitaminlab.com/personalized to save $100 off your first formula.
I've read some books on dementia prevention, and they always mention homocysteine, but they have a list of hundreds and hundreds of labs. And I find it interesting that you started with the cholesterol labs and keeping the blood vessels healthy, because so many people consider Alzheimer's to be type 3 diabetes, or some, have some glucose destabilization component to it. What do you think about running glucose labs, the importance of insulin sensitivity here?
So big. I think there's a reason why we all call it type 3 diabetes, though not every dementia case is a type 3 diabetic case. There's good reason going back to histology. So if you look at the brain, and if you ever study the brain, we all have different lobes, the frontal lobe, parietal lobe, temporal lobes. And amongst the parietal and temporal, you have the hippocampus. And it's this part of the brain that encodes your short-term memory. But if you look at the histology of the hippocampus, if you compare that to other parts of the brain, the hippocampus expresses about 40% more insulin receptors than any other part of the brain. In other words, the hippocampus requires more fuel or more glucose to be able to function. Though I find a lot of insulin resistance in possibly 80% of my cognitive health cases right now, and I'm working on them. And by establishing better insulin sensitivity, the hippocampus is able to then obtain glucose and be able to function, and thus be able to encode for short-term memory, which happens to be one of the more common first signs of cognitive decline. So definitely when it comes to your metabolic health, and I find insulin to be number one in testing for blood sugar and looking at things like even blood glucose and HbA1c, even though important, you find insulin resistance happening despite having normal levels of HbA1c and glucose.
You're talking about a fasting insulin test.
Yes.
Yeah, it's so cool. I mean, I'm obsessed with how difficult it is to maintain an optimal range. So say we're talking about fasting insulin and then using a fasting glucose at the same time and publishing a HOMA-IR number. And, the calculator that I use has listed less than decimal 9 as optimal. And to reach that, you need to have incredibly low levels of insulin at the same time as a fasting sugar that's really looking good. Mm-hmm. Do you find that to be difficult? Like, what kind of targets do you set? They say percentage reduction in HOMA-IR, or do you focus on HOMA-IR? How do you do it?
Oh, big time. HOMA-IR is big, and I have a few patients I could share about using HOMA-IR and looking at their changes. But I understand and I clearly agree with you. The conventional range for fasting insulin, I think it's like 20 to 180 picomoles per liter in BC at least. And if you play around with the HOMA-IR calculator And assuming you have a normal or a really optimal blood glucose level, fasting glucose level, you'll find that when you get to your HOMA-IR at about 1.9, 2.0, so we call that early insulin resistance, your insulin's already at about 50 picomoles per liter.
Yeah.
So anything above 50, you're already at an early insulin resistance. So that's already really low to begin with, right there.
I completely agree.
So looking at that, HOMA-IR, one patient I have, a recent one too, 91-year-old female of Asian descent, coming in for short-term memory loss brought in by her family. And she wouldn't be remembering much about where she left her wallet, her keys, where she's at. She's had times where she would walk into a room and isn't remembering where she's at. And for this case specifically, on top of the short-term memory loss, she would have these kind of episodes.
Like delusions?
Like delusions, yeah.
Yeah.
And she would be locking herself in a room saying everyone's kind of stealing from her and she's trying to keep herself safe. And these episodes tend to happen quite randomly. But it was quite interesting for me to think short-term memory loss with a 30-year history of diabetes. So she's already been diagnosed as type 2 diabetic, HbA1c at 7.8%, where you want to be lower than 6.0, and my standard lower than 5.5. And having tested her fasting insulin, it was about 150, 160. I remember her HOMA-IR was about 6.0.
Right.
So insulin being 6 times more resistant than what we want that to be. So we worked a lot on kind of maintaining the blood sugar and also trying to get the insulin to be sensitive. There are a number of supplements and pathways to make insulin more sensitive. But it was interesting after looking at her diet that there was a lot of simple carbs. And I found some correlation behind simple carbohydrates and the delusions that she was having. So the family suggested if we could do a continuous glucose monitor. And we went about with that, and we had her monitoring her blood sugar for 2 weeks and found that there was a threshold for these episodes. And when her glucose goes beyond 14, that she would have these episodes. So it was quite intriguing that there was a threshold for these kind of mental health symptoms to arise just by looking at blood sugar.
Yeah, that really is. Wow, that must have been challenging with someone with dementia to be doing a continuous glucose monitor. I never considered doing that, but that was a really great finding. I mean, so this is an important component to this. I don't know, do you ever assess for example, the omega-3 status or nutrient status in people, not necessarily to help them overcome insulin resistance, but maybe as a package for someone who's experiencing memory loss?
So normally I would have kind of one of two panels that I would test. One, normally I call this the prevention model or the prevention panel. And this is in BC, we test the Enhanced Healthy Living panel by Life Labs. So that includes your vitamin B12, your vitamin D, your insulin, your blood sugar, HbA1c, thyroid, iron. Those are all connected to, in many ways than one, with cognition. So I would do that along with homocysteine. Not necessarily just for the insulin aspect, but dementia and cognitive decline is a collection of a number of factors happening in the body. Things like B12 deficiency, inflammation, hormone deficiencies, toxins, heavy metals. We can go on and on about that. So I'm just looking at what's going on in the body and how can I help the body to be able to help the brain from there.
Yeah, it's a great panel. When do we know that we need to go deeper? Say, for example, like you just mentioned a few functional tests. And I bring up the omega-3 test because it's a favorite of mine in cardiovascular risk reduction, but I just don't know about the value of it in dementia prevention. But I just wonder about these advanced tests. Like, for example, a lot of labs now offer nutrient assessments like B1 and red blood cell magnesium and methylmalonate and more comprehensive tests that might include 100 different nutrients, for example. And I'm having trouble in my clinical practice deciding, okay, is it time for me to go all in here? Or should I go all in, say, on the environmental pollutants assay? How do you make these judgment calls? What's the type of client, the type of patient that you're working with where you do this kind of work?
It's a good point because there's so many tests out there, and I love the omega-3 score. I love a number of these panels, hormone testing, and so forth. When do I figure out, or when do I think I have to do these panels over other ones? The history is going to be very important. That's number one right there. If I find, even though it sounds like we can generalize dementia being, oh, if it's dementia, we have to do all these things right here, that's one thing. Number one factor is progression. If your patients are progressing more slowly, like over the last period of 5, maybe up to 10 years of decline, and the family's mentioning that, yeah, it's been like this since the last 10 years or so, I'm looking at more metabolic. And from there, I would start testing for insulin. I would want to make sure that things like the homocysteine, cardiovascular markers, blood sugar, and even inflammation is addressed first. If it was an abrupt decline, we had to find out what that abrupt decline means. Was it after a stroke? Of course, that clearly means that there was some vascular component to that. So we have to look into, then is it homocysteine? Do we look into other things? And now there's some really interesting functional tests. I don't think we have access to them yet, but been looking into, I don't know if you're familiar with TMEO.
I am familiar.
As a marker of that, of the gut marker of cardiovascular health. It's intriguing to me. But even things like if it wasn't abrupt decline but had no cardiovascular involvement, then I'm looking into, is it a toxin involvement? So this is where we have to look into heavy metals, mold, environmental factors. So that's first thing right there when it comes to the history. And then I look into things like what domains are impacted. So most common, everyone's going to say dementia equals short-term memory loss. Well, that's probably about 80 to 90% of cases as the first sign and symptom of cognitive decline. And that's, very classical right there. But what if it was something else? Something like rigidity of movement. Then we're looking into something like Parkinsonian's dementia, frontal temporal dementia, or even Lewy body. But I think of Lewy body more so also with hallucinations. So the history is going to be very important. And just by having someone come in and say the term dementia, it doesn't kind of check anything off for me yet until I start getting to know more of my patients.
Yeah, that's interesting though. But I like that way of framing it, like the slow progression over 10 years versus the abrupt decline. I had a case very similar where I used a structure like this, but not on purpose, where it was a rather abrupt decline, and we found significantly elevated heavy metals, and actually lowering them had positive benefits on cognition. So it's a very exciting case for me, and I was thrilled to see that. So this is good, and we'll get into a little bit more about those functional tests and the more comprehensive environmental toxin assessments in a little bit. But I've got another question for you that I want you to help me with. How do you differentiate between normal aging, mild cognitive impairment, and early dementia in your clinical practice? Like, what are the subtle signs people miss, and how do you assess?
It is so interesting to talk about this only because we can take it from one aspect, and that is comparing those that we see here in, I guess we can call it the built environment, but seeing our current community and comparing that to those that are in the blue zones. So these are individuals living in an area where there are older adults living beyond 100, or what we call centenarians, and seeing and comparing between the two. But what is normal and what is abnormal aging? There are so many different definitions when it comes to that. And I think what is normal aging is we do experience some form of decline, especially in terms of our cognition. We're potentially bound to be losing some of our memory. I think what we can also define as abnormal is when you lose too much of that cognition. If you've declined too much and it's impacting your activities of daily living, that's when it becomes very concerning. So if you were someone who was functioning, I've had some patients just recently come in and say, it was only just 3-4 years ago that my patient was cooking on their own and they're bathing on their own and dressing up on their own. And suddenly they're at this point where it's just challenging for them to do anything. And it's been only just a short few years. So that kind of progression, that kind of decline is technically abnormal. I would love to say that you would want to be seeing that progression maybe over a span of 20, 30 years rather than a span of 3 to 4 years. So it's looking at the trend.
That makes sense. I did not expect you to say that.
You can also look into other things. There's actually some clinical guidelines and some charts that an easy image right there. It's called the clinical frailty scale. So if one is getting even more frail, they're putting themselves at more risk for developing some form of cognitive decline. And why I love using the clinical frailty scale is it's just a picture of 10 different individuals where you have one being a very fit individual being able to move anywhere and everywhere, and they're able to perform their activities of daily living. And then you have on the other end, someone who is either bound to a wheelchair or bedridden for potentially the remainder of their lives. So looking at how vital and how energetic one is can also be a good determining factor in looking at cognitive decline or decline in general.
Oh, that's excellent. I feel like part of the fear that a lot of naturopathic doctors and practitioners in general have is getting into doing assessments, right? Getting into doing Montreal cognitive exams or even just mini mental exams in the office. It can be very stressful and challenging for everyone in the room. People do not like doing them. It takes 15, 20 minutes or longer even to get through these exams. And I find myself sitting and saying, what's really important here is that your ADLs aren't possible. Like you can get through your activities of daily living in a positive way and your life's not disrupted significantly by this. And I think what you're doing here is giving us a bit of freedom to say that we can take that approach. Like, if someone comes in and they're worried, we don't have to have an absolute label, right? To say this is mild cognitive impairment. Who cares about the label? We've got insulin resistance. Who cares about the label? We've got cholesterol that's been elevated for 30 years because they don't think it's a big deal. So I think having that freedom, and I would love to see this. I don't even know what graph you're talking about. I'm going to look it up as soon as we're done. But to have that in front of us, right? Like to say, okay, you're on this part of this line, and we need you way over here. That gives us so much more time to chat and to build. And I think that the relationship between the integrative physician here and the patient is really, really important because it can be difficult to communicate with people who are experiencing memory loss. There's a lot of challenges for treatment. So is that a good summary of that? Like, do you agree with those comments?
I hugely agree with you. And these are factors where, what we're talking about with things about dementia prevention is that the earlier you do it, you see where your baseline's at. I think that's also a very important concept, is setting your baseline so that you know how much and how far you're declining. That goes back to answering your question about what is normal and what is abnormal when it comes to natural aging and natural decline. But even things like insulin resistance, cholesterol, potentially homocysteine, and even inflammation, these things change at least a decade or so prior to even seeing any type of symptom when it comes to dementia and cognitive decline. So doing these things of working with insulin resistance, even if you don't have these kind of symptoms, is going to help you down the road. And I really love just how you phrase that.
This is opening up a big can of something for me here, because we do a lot of fasting insulin assessments, and we see a lot of insulin resistance for sure. And we say, okay, diabetes is around the corner if we don't change the lifestyle and clean it up a bit. But maybe a better motivator would be to remind people about the impact on the memory. Diabetes seems so there's so much uncertainty around diabetes, right? Oh, my foot is going to get numb in 10 years if I don't start exercising. Whereas short-term memory, it's in your face. They know people who have experienced that, where not everyone knows someone who has a numb foot or pees a lot, right? Or is losing their eyesight from diabetes. I think this is actually really, really, really cool. I'm going to start using this with my younger people, because we have a lot of people who are coming for heart disease prevention, and they're doing it because it's in their families. But I feel like this is quite inspiring, because we're all so cerebral now. We're all really interested in being smart and having a high level of cognition. And so having that conversation with people, I think, will be really valuable. And as integrative practitioners, naturopathic doctors, I feel like we have this really cool space where we can spend time and do this work, but we can also take it a step further and look at functional assessments. And some of my favorite ones in this population are typically driven by patient desire. Hey, I had mercury amalgams for 30 years. I didn't know they expired. I'm worried if my mercury is high. Or, hey, like I used to paint houses and it was lead paint. I'm worried about my brain because of the lead paint. Should we check this? Nowadays, we've got phthalates and parabens and environmental pollutants all over the news that is part of my feed, my algorithm. And people are concerned about that and them settling in the brain tissue and impacting them long term. And I know that they're very expensive and that they're not first line compared to the things we've already discussed. But can we talk about some of those panels that might be your favorite? And could you tell me about your approach to these?
So I'm going to touch base on the heavy metals. But before that, I just want to quickly say that there was something that just resonated with me, what you mentioned, David, about the idea of reframing. And I think if we reframe the idea, I know I work with more older adults, and a lot of them don't really like the death sentence of dementia. But I'm not here to give you that death sentence. What if the possibility was to optimize your brain health and just get your brain working better? That's the biggest thing for me. Sorry, I just had to bring that to light.
It's a really good point. It's like we talk about it with body composition change, right? That's my shtick.
Yes.
Is body composition change. But mental emotional fitness, cognitive fitness, these are really, really, really good goals that people often don't set. I wrote a newsletter this week about the benefits of mindfulness and tried to separate out, the different techniques of mindfulness-based stress reduction, mindfulness-based cognitive therapy, and the evidence around these. And it actually got me thinking about our chat today and about how when we challenge the brain, it gets stronger, and how it really does act like a muscle in that way. It's the same thing in anxiety and depression. When we take a step back and look at our responses to our both in our external and internal environments, we get better at managing the implications of those environmental factors, both external and internal. And that translates into like a less stressed body and a better mood, which for a lot of people ends up causing better energy, which means their cognition's better. Mm-hmm. So yeah, I'm all in, man. I love that stuff.
Environment, very big right there. And I think there was a recent, I think it was either Instagram or Facebook, but I think both of them are pretty much the same nowadays, that even traveling is good for the brain only because you're putting yourself in a different environment, and then your brain has to adapt. Your body has to adapt. And that goes for any of the cognitive challenges and the cognitive training that one does. I hear people, same patient, that 91-year-old patient that came to see me would say, well, I read the newspaper every single day and that's good for my brain. And I would ask her, well, what did you read? Well, I read the newspaper, so it's good for my brain.
Yeah.
But even things like Sudoku and crossword puzzles and all that, even though they do have their place in the environmental aspect, I call it the environmental aspect of challenging the brain, if you get used to it, then the brain's not going to want to adapt. So you have to change, you have to do new things, learn new hobbies, learn new skills, try learning a different language, go travel somewhere that's completely new, try taking a different route when it comes to your own commute. And your brains are just going to work differently. Use your other hand when it comes to brushing your teeth. There are many small ways that you can just get the brain to not feel comfortable. Because once it gets too comfortable, it's not going to want to reinforce pathways or make new pathways because you've already reinforced the current pathways.
Is that just what aging is? Just getting too comfortable?
Come to think about it, I think that's a good point.
It's a big part of it. Yeah, we're obsessed with this. Like we're trying to do everything for our kids to give them the best possible, kind of start to life and the most opportunity. And we were reading about how if you travel when you're young, it's good for the brain. It's good for cognition. Yeah. It makes kids smarter. So we're like, okay, how can we travel? We need to start traveling because we want our kids to be smart. So yeah, any age. These new experiences create new connections. I love that. Okay, tell me about functional assessments. Let's go deeper into my world. I don't know if it's your world or not, but I just love functional tests. Tell me about your experience.
I mentioned there's two panels that I do when it comes to cognition. So this is going into the second panel now. And one significant component of that panel would be heavy metals. And if I do find that not only are the symptomatics showing for someone coming in with cognitive decline, but the progression was more on the faster side, we're going to be testing for, at least to begin with, blood mercury, blood lead, especially now that we have old plumbing that's mostly entirely lead, and we have amalgams and such. So those are some of the tests that can be done when working with me for the first time. And then now we have other functional tests to do with urinary analysis, to do with heavy metals and such. Now, I don't have my chelation certification just yet. However, when it comes to heavy metals, there is still a big component in testing. I'm not sure yet about the pros and cons about blood versus urine and all that. Maybe you can teach me more about that in the near future, but definitely one component of cognitive testing. Other tests that I like to do in my practice include the omega-3 score, looking into the ratio between EPA, DHA, omega-3s, omega-6s. That's very important. I know it is more on the costlier side, and that's why I like to do the foundations first before we get into the omega-3 testing. But we've done a number of them, and it's really eye-opening to see how high the ratio can be from between omega-3 to omega-6s nowadays.
Oh, definitely. Yeah, I'll comment on the heavy metal assessment. The blood and urine, like just a straight up urine, is very similar to the blood. It's just reflecting what they've been exposed to in the previous few days. But it's the provocation assessments that you do in the heavy metal course, where a person is taking a chelating agent and then doing the test following that consumption, whether it be oral or IV chelator, and then they see how much heavy metal was pulled from the tissue. And it's a really tricky test, and it's not a perfect test, but very often shows more than just a single urinary snapshot.
But that's also a big component when it comes to not just cognitive health, but our overall well-being. There's always the saying, we are what we eat, but there's also the saying about how we eliminate what we're eating. And elimination is not just from the form of fecal matter, but urination, sweat, the breath. So skin is very important if we're not sweating and if we're not forcing ourselves to go through some form of detoxification or facilitating detoxification. And that's important too.
Absolutely. Yeah, great point. No, are you ever doing, this is the place where I wanted to end this part of the conversation was on the amyloid and the tau test. I haven't done any of these. Any of the newer assessments for active plaque buildup in the brain?
So at this time, we still don't have access yet, at least in British Columbia. That is in the works, though, I will say. But I do have patients that will run over to the States and get their p-tau 217. That's been currently the most sensitive test for tau tangles. And then there's the beta amyloid 4240, which tells us more about the beta amyloid plaque burden. It's still new in terms of the evidence about clearage of the amyloid plaque and the p-tau 217, because if you think about it, conventionally, there's already been several hundred clinical trials of pharmaceuticals that attempt to get rid of the beta amyloid plaque, and majority of them not as positive, some more so. But it gets to the idea of understanding why plaque is built up in the first place. And I think that puts us in a really good position, only because we're always wondering, why do we make plaque? There's theories about the inflammation theory, that plaque is made to prevent the brain from being inflamed in the first place. But by being overly inflamed and you're producing too much plaque, it becomes a double-edged sword. So inflammation can be one. Plaque has been found to be also antimicrobial. And in a number of the post-mortem studies has shown that there's through, I think it was PCR studies, so there's also pros and cons of that, but to find genetic material of bacteria in the plaque that is correlated to the bacteria that's coming from our oral cavities. So having proper oral health is important to be able to mitigate that microbial buildup into the brain.
I'm so glad you went there because that's exactly what I wanted to be talking about and where I wanted this conversation to go. It's the microbiome, bacterial, viral, fungal cause, whether or not we think the gut-brain axis is important here, whether we think or not antibody assessments for chronic infections are important here. What do you think about the microbiota and assessments or tests really in this realm, working in prevention, remember?
Hmm. So, not quite familiar, however, have dug deeper into microbiome analysis and microbiome tests. I know there's so much about the microbiome that we still don't know yet. There's like, what, hundreds of thousands of strains? And so far, we've only scratched the surface when it comes to maybe knowing and understanding a couple hundred strains. But we're understanding, and there was this kind of push and movement in the last year or so about understanding what prebiotics and probiotics are, but now there's this new term, postbiotics, that we're getting into about what the probiotics are creating and how is that then supporting the brain. And one of those postbiotics that is starting to shed light is butyrate. I think a couple papers out there about butyrate and neuroinflammation, and we know that butyrate is being transported back and forth via the vagus nerve. So there's this connection between the brain and the gut. But that's pretty much what I know so far about it. I know with also other infections that you've mentioned when you mentioned virology is the herpes virus. I think there's some connection going on right now about the reactivation of the herpes virus and potentially having that correlated with cognitive health as well.
Wow, that's interesting. And all of a sudden now we're 40 minutes in here and you've built a complete holistic approach to brain assessment, right? I mean, I guess we're missing one component that just kind of came to mind as I always think about my holistic approach. We're missing out on the hormone piece. So where do you think the role of hormones are here?
There's correlations now about, there's always the saying that why are women more prone to develop Alzheimer's disease versus their male counterpart? Could hormones be a factor? And one of the hormones in question is estrogen. Estrogen is neuroprotective. It can help support building neuroconnections. And once a woman goes through menopause, there's that risk of, I guess during that transition with perimenopause, there's always going to be some of those mental lapses and cognitive shifts when one goes through perimenopausal stages. So there's kind of those connections right there. And there's this growing, I want to say study, but also there's been some schools of thought about starting hormone replacement therapy about the time you're getting into perimenopause and menopause, at least ideally, no further than 5, maybe 10 years post-menopause. Looking into the evidence, there is other ways that one could go through hormone replacement therapies because conventionally we look into equine hormones, but now there's more bioidentical hormones and there's now more forms and methods of taking hormones such as topicals and patches and so forth. So there's this growing idea of hormones playing a big role in maintaining and even preventing cognitive decline in the latter years.
So we've gone through this holistic approach and to assessment. Now, this leads me to this question. Do you think that this, with the amyloid hypothesis, we have been led astray for decades? Like, is this really about optimizing the function of all the organ systems, or should we still be focused on amyloid? What do you think?
I believe taking this holistic approach is key. And the reason why I say this with confidence is because if you look into the pathophysiology of the amyloid plaque process, you come to a couple of genes, but you'll look into the amyloid precursor protein. So let's look at that first. And that amyloid precursor protein will be converted into one of two things. And, surprise, we make plaque normally. We make plaque. We are meant to make plaque, and plaque is meant to be good. That's the shocker right there. But there are two pathways. You either make this amyloid precursor protein go in to make what we call soluble plaque. And soluble plaque is needed to make new neural connections. So that is programmed in us. So that requires us to cleave this amyloid precursor protein at certain stages to be able to make this soluble plaque. But what's happening and why the plaque hypothesis is because we're making plaque due to the second pathway, and we're driving the second pathway, or at least those that are going through symptomatics are driving this pathway. And this pathway will make something called insoluble plaque. And that's also known as what we know today as beta amyloid plaque. And in order to do that, you must cleave at the beta site via the beta cleavage using the gene BACE1. So there's been more research about the BACE1, and even in terms of the pharmaceuticals, they're looking at how can they prevent the BACE1 gene from then creating the protein to cleave at the beta site to make this insoluble protein. But in terms of the animal studies at this point here, there are a number of factors that would turn on the epigenetics of the BACE1 gene, and factors such as inflammation, factors such as hypoxia, which is really big. Hypoxia, when do we have states of low oxygen? Think about anemia, think about sleep apnea. These are also contributing factors to cognitive decline. So the reason why I'm also bringing this pathway up is by making beta amyloid plaque going into the second pathway that is creating the insoluble protein, there is a positive feedback loop. So even if when you make beta amyloid plaque, you're driving that pathway even more. So the solution then is not to just get rid of the beta amyloid plaque. Because even if you have pre-existing beta amyloid plaque, that pathway is still driven. So that's why you have to go back upstream and to look into the factors that puts us in a position where we're creating the soluble plaque. That's where lifestyle, that's where nutrition, that's what we do on a daily basis that determines our overall well-being and our cognitive health.
Wow. I did not know that. That's super interesting. And you brought up the hypoxia component here, which is fascinating to me because people come to our clinic for exercise with oxygen therapy, right? So we give oxygen while exercising, and people feel amazing and they feel more focused. They feel like their cognitive health is improved following these sessions. And I'm really excited to hear about these differences in plaque because I had no idea. I think that'll really resonate with people. Like, it feels like so much of the approach is just, keep your cholesterol low and don't make your blood sugar go too high. But to know that it's influencing a pathway like this, so be the fittest you can possibly be so that your oxygenation is really, really good, but to not be nutrient deficient because iron deficiency might drive this. I think that can be quite empowering and can really help to inform a really good holistic approach that people can do at home that doesn't require a lot of medications or a lot of interventions that are supplements even.
It gives us the why. That's the thing, is we need to know why. We're not just doing a bunch of random things to help mitigate our risk and progression of dementia, but by understanding what people have these predispositions to cardiovascular health, sleep apnea, nutrient depletions, hormone imbalances, etc., and so forth, that gives us more of a personalized approach to brain health.
I suppose there's probably a few other aspects that can't be assessed that we should probably cover, because you've mentioned a few there that are assessed, though not with labs. But what about in your questioning, in your consultation, you probably are speaking about social isolation and hearing loss and mood. Can you comment on those ones a little bit?
Social isolation was my PhD comprehensive exam.
Oh, wow.
So I did a lit review on social isolation and how it contributes to both the physical, mental, and the emotional, and the cognitive components of our health, especially with the efforts of the COVID-19 lockdown. And there is so much involved in social isolation, which is really, you can't really measure it in a petri dish or a lab. So of course, investigating about not just are they socially interacting with others, but are they wanting to? have their interest in socializing, have they decreased? So that is also a key question in my questionnaire. And things like other things include, we talked about the environment and mold and heavy metals, but even questions like how old is your current house, any history of water damage or even mold infestations, those are important. Things like physical activity, we talked about in your case with the oxygenation and the VO2 max, which is also very big in brain, but looking into physical activity. And there's also ways to assess for how vital a senior is, not just with the clinical frailty scale, that's one thing, but there's also the dynamometer, so grip strength. So assessing, that's just a quick 3-second thing to really see how strong they are. And that's a great factor in assessing how their lead muscle mass is and their strength, grip strength, and correlations between grip strength and cognitive health. So much more that can be done and should be done in the visit.
Oh, completely. Yeah, I did not have grip strength on the list. That's a wild card. Thanks for that. That's excellent.
Because there's so much about muscle. And another thing that I think is growing in terms of being measured, I feel it should be measured sometime in about the next decade, is BDNF, brain-derived neurotrophic factor.
Okay.
There are some labs that are looking to start testing for BDNF, BDNF being our fertilizer of the brain. But in order to create BDNF, we need to have lean muscle mass. This pro-BDNF happens to be made in the muscle.
Interesting. I knew it went up with exercise, but I didn't know that is it a hormone? The pro hormone
The pro-hormone, yeah, the pro-BDNF,
is made in muscle.
or the immature BDNF, whatever you like to call it. There has been some recent studies in 2024 suggesting that the pro-BDNF is made in the muscle. And by engaging muscle, so when you're contracting muscle, you're really getting BDNF being made.
So we have a comprehensive approach to assessing someone who's concerned with their memory. And we started with genetic test, ApoE. Talked about 2, 3, 4. Then we went into cardiovascular assessments, including ApoB and healthy living panel from our local lab that includes liver, kidney, inflammation scores, anemia assessment, and so on. We talked a little bit about nutrients. We went into functional assessments that included heavy metals and mold and so on. And we finished up with some really, I think, important lifestyle assessments. So, for example, the social isolation, the sleep apnea, although that's not lifestyle, but it is assessed in a sleep study. It's very comprehensive, and it can seem overwhelming. I think if you're a practitioner like me who's not just focused in this one field, it's helpful to be working with someone like you where you do this full time. But there's a lot of pieces we can pull out from the cases that we have. I'm thinking specifically about fasting insulin and HOMA-IR and having this conversation around metabolic health, right? And memory and cognition over time. But the one thing that I really want to take from today's session is this point about the different types of plaque and how they're driven. The decision is probably partially genetic, but the epigenetics of this is that the lifestyle turns it on, right? So
Absolutely.
you brought up the hypoxia component, and I'm going to go try my bike right now, get that oxygen flowing.
Yep.
Anything else on the assessment side, Dr. Fung, that you want to share with us today that you think is important?
I mean, we can go really deep with the assessments, and there's a number of other tests and other labs from national and international labs. I know there are labs that would test for neuroinflammation, for example. And I think there's some lab panels that will indicate autoimmunity or antibodies against the blood-brain barrier. So these are also factors that are looking to be identified. I'm looking into other things that potentially could be done. I think there's some studies that show it's intriguing where dementia and Alzheimer's disease can actually be viewed through the eye. And I think an ophthalmologist at some time, perhaps in the next couple of decades, could be able to detect that. So there's a number of factors. There's NFL testing, neurofilament chain of light, and that's telling us about traumatic brain injuries, which is also a big contributing factor to dementia as well. We have growing numbers of other tests. GFAP, I think, is going to be also interesting. Glial fibrillary acidic protein, which tells us a lot more about the neuroinflammation coming from serum and blood.
Wow.
So it's intriguing how there are a number of tests that are in the works, and perhaps they could be mainstream, but they will give us more accessibility for assessment when it comes to where you're at with your cognitive health and what do we need to approach when it comes to your cognitive health.
Oh, exciting times to come for us. That will be great to have something very specific to the brain, so we didn't have to talk about metabolic wellness all of the time, to have one measure that we're tracking over time. That will be very exciting. Well, thank you so much for your time, sir. I really appreciated going through, top to bottom here. This is how my brain works. I like to have a big circle of what is this holistic approach? Like, how should we be actually looking at this one organ system by considering the whole? And you really did it today. So thank you so much. Where can people connect with you online or learn more about your clinical practice?
I can be easily found through Google Dr. Romi Fung, or there's my website, www.drromifungnd.com. And you can also find me on Facebook and Instagram. That's Dr. Romi Fung ND.
Thank you so much, Dr. Fung. I really appreciate you joining us for round 2 today. That was super enlightening, and I'm glad to be able to share this with our audience here at Personalized. So thanks again.
Thank you so much for having me, Dr. Duizer.
Talk soon. Bye.
Take care.
Thanks for joining us for today's discussion. What about today's podcast resonated with you? Be sure to tag at Dr. David Duizer and at Get Vitamin Lab. If you're learning from and enjoying this podcast, please let us know by subscribing to our YouTube channel and follow the show on Spotify and Apple. And don't forget to leave us a review. It's the best way to support our podcast, and it helps others find us. To learn more or book a demo to explore what personalization could do for your practice, please go to www.getvitaminlab.com/personalized.